Ordinarily, I would be talking about a number of different things in neuro-ophthalmology, but we have a very specific title to this portion of the course, which is on clinical trials. So I apologize because many of the slides are going to have, in fact, have been lifted from the two talks that I was able to give yesterday over at Stein, because it pertains specifically to the issue of clinical trials. And it's an interesting thing in putting this together for me to realize, as this financial conflict slide points out, that I had never anything to put up on these financial conflict slides because I never had any trials going on. For 30 years of working on Lebers. And then the last 3 years has been an explosion of interest in the field. So in fact, GenSight and Stealth Biotherapeutics have been funding 3 of these prospective double-blind trials that we'll talk about today. But I now have 5 trials going on in just one disease, Leber's Hereditary Optic Neuropathy, which is to me staggering since I never could get anybody to pay any attention. And maybe a little bit is the success that we've had in our own research on Leber's, and I think a lot of it is due to the fact that outside the field of ophthalmology, indeed, there's been a renewed interest in mitochondria and their role in disease, which has been nothing less than exuberant. So starting just with a very little background about Leber's, this is a mitochondrial disease. It's an inherited disorder of metabolism, but it comes about from the 13 genes that are from the mitochondria as opposed to the 30 or so thousand genes that are nuclear. The patient presents usually in a very surprising way for him and his family. They're unaware of the fact that there's anything running in the family because the penetrance, when the nutrition is good and when the living habits are good, the penetrance is not very great for the disease. So you have all these carriers who never demonstrate any aspect of disease. And then typically, as I show in this slide, a young man who starts to live in the fast lane by going to a fraternity, smoking and drinking, suddenly loses profoundly his vision in one eye, and then a few weeks later in the other eye. And actually, typically that happens in the United States around Thanksgiving, because that's just enough time to get used to this fraternity lifestyle. And typically, and this is an important point, the delay to diagnosis in Leber's is almost always 3 to 6 months, perhaps a little bit shorter in California than in places in the middle of the country or places that don't have neuro-ophthalmology available. But that is an important issue to keep in mind as we talk about treatment. The simplistic version is that the mitochondria carry these 13 genes for oxidative phosphorylation, and the issue is all about oxidative phosphorylation. Nobody argues about that. I'm going to push a button on this to see if I can get the laser going without advancing the slide. Good. And this is not exactly right, but mostly your electron transfer goes down the chain of complexes while causing a proton gradient. The proton gradient is exploited to make ATP. So one of the issues of controversy that I've been struggling with for 30 years is it the ATP that is depleted? Is this a disease of bioenergetics? Or is it the reactive oxygen species that is generated when that electron spills out of the chain? And I think that finally, and I was glad to say I was on the right side of history on this one, finally this paper that I was fortunate enough to get involved in from PNAS has resolved the issue. It's about the ROS. Because we finally, when I say we, I should say the senior author, Doug Wallace, for 23 years has been working, and literally millions of cells have been mutated until he got the mutation that we were looking for. And so we now have an animal model of the disease. And in the animal model, you can show the decreased complex 1 activity that you expect. You can show tremendous rise in reactive oxygen species due to that spilled electron. But there is no significant change in ATP production, which in fact replicates the experiments that I've done with my Italian colleagues in cybrid experiments, but here it is in the full living system, and so it's about the ROS. So therapies have to be aimed, in regards to ROS. This is the model of the whole thing, and I will mention here to this group because some of you might remember, this is a drawing actually of Michelle Wang when she was a medical student at USC. And it's now reappeared in many books and many papers with a little minor alterations for copyright issues. But this is sort of the model of the disease that says complex 1 is where the problem is. Because of the mutation, it cannot transfer its electron to 3. 2 does, and from 3 on it works fine. But this spilled reactive oxygen species, when it gets to a threshold level, often aggravated by exogenous factors like smoking and excess alcohol, generates enough of a change to the mitochondrial membrane, which is sensitive to reactive oxygen species, as a signaling system. It's built in to be that way. When it gets to a critical threshold, it causes a pore to pop open that sets off apoptosis. And that happens where the mitochondria tend to accumulate. And the mitochondria tend to accumulate throughout the central nervous system, especially at the nodes of RON-VA, where the work is being done, where the myelin is not. And the longest node of RON-VA in the human body is where we work, in the retina. Since myelin is not transparent, the retinal nerve fiber layer is not myelinated, and that's where the crisis tends to occur. So we understand this pretty well now. Why don't we have a cure, a fix? Well, to start with, we have problems that there is so much delay that we usually end up seeing optic atrophy, and the axons aren't there anymore. And to give you a sense of how much that is, in the typical case of Leber's, 95 to 98% of the axons die. So that's a hard thing to recover from, and that's one problem. We could theoretically want to deal with the patients who have just newly converted. That would be ideal, but as I say, there's a delay to diagnosis, so we have few options of doing that, except, and that's where our clinical trials are successful, in those cases when we're dealing with the siblings or at least cousins of people who've already been diagnosed and sort of entered and know what the diagnosis is, know what the molecular characterization of their mutation is, and know us. Carriers often approaching me, patients from those same families, and saying, I'm scared of this disease, I want to be treated. But my feeling, very firmly still, is that we should not be treating them because these carriers can usually be prevented from going blind by simply following the simple precautions of avoiding alcohol and tobacco. The penetrance rate that is published for this disease is about 50% for males and about 15% for females, but that's taken all comers. And for those who are females who do not smoke and drink, the rate of penetrance is about 0. And for males, it's probably about 10%. So do you want to subject somebody to a lifetime of treatment when they're running between 0 and 10% likelihood of having disease? And so far, I have not been convinced that the risks of treatment can be overcome to do that. So we're only going to be talking about treating this group. Now, as a review treatment, I want to first mention what doesn't work, and excellent studies have been done to show that the obvious treatment, which is give it vitamins, give it free radical scavengers, deal with those reactive oxygen species, don't work. Much of it has to do with drug delivery. It's easy to get drugs like coenzyme Q10 into a human body. It's hard to get it out of the bloodstream and into cells, and it's nearly impossible to get it through the cells, from the cells to the mitochondria, which is where you need it. Now, these are extremely lipophilic molecules, and they don't go through membranes very well. But a second-generation coenzyme Q10, idebenone, represents one of our trials. It's an open-label trial. Another, third generation, is EPI-743, another one of our trials. But the two prospective trials we'll talk about today are involving gene therapy, where we actually are sticking in a new ND4 into the mitochondria via a viral vector, which is injected into the vitreous, and an agent which is, goes about dealing with the mitochondrial problem in an entirely different way. The open-label trial is idebenone. We've already published some of our results here in Brain at the same time that a prospective trial on idebenone was published. Each of these trials have major deficiencies, but taken together, it proves that the drug works. Our deficiency is ours is a retrospective open-label trial. The deficiency of the group in Newcastle, England, that ran this trial is they only ran it for 6 months, and they used as a primary outcome measure visual acuity. Visual acuity is a terrible way of trying to measure things in Leber's, where you start off with a large central scotoma that just gets larger on the edges and doesn't really affect visual acuity very much. So that was problematic, but taken together, I think that we know what's going on. Their trial, the prospective one, treated 2/3 of the 85 patients with very high doses of idebenone. As I say, they looked at visual acuity at 6 months and didn't find any positive results with that. Our trial was a retrospective trial with 103 patients treated, and we looked at them from 4 to 5 years, and we were able to find effects. In fact, these effects are best summarized in this Kaplan-Meier curve from our results, which shows that the untreated patients versus the treated patients at 6 months hardly vary at all. And what's interesting is that idebenone continues to work for 2 or 3 years, where the differences between the two groups tend to stabilize. And the same thing seems to be true for Epi-743, which is this work here. It's a really interesting molecule, which is a third-generation quinone, which not only allows the electron to be taken up, but resent back into the system at complex 3. So theoretically could even add to the bioenergetics, but I think that's not important. But anyway, we have had some dramatic results that I'm going to share with you now with that. This is a patient who, for a year, showed no improvement whatsoever, but then at 16 months, suddenly his scotoma shrunk and his vision went from 2400 to 2030. And that's in one eye, and in the other eye, very similarly, went from 2400 to 2020. So this is one of a very few number of patients who've had regular 11778 Lebers. That's the one without spontaneous remission, who is now driving on the highways of California. Beware, he's in the southern part of the state. I think one of our breakthroughs was convincing the FDA to go to a different model of clinical trials. Of course, they want double-blind, placebo-controlled standards in order to give their approval. But instead of having it as they wanted to do it, one patient yes, one patient no, we've been able to convince them to the paradigm of one eye yes, one eye no. Taking advantage both of the fact that the eyes in any given patient are incredibly symmetrical with this disease, and therefore the science is better comparing the left to the right eye, although randomly selected, neither the patient nor I know which eye gets treated. And secondly, that the ethics are so much better that we have an agent, idibinone, that works, which, by the way, I forgot to mention, approved in Europe, is not approved in the United States. And therefore, to deprive patients of that treatment without offering them at least one eye that is treated was, I think, an ethical problem. But furthermore, as everybody in this room fully appreciates, the beauty of ophthalmology is you are as good as your better eye. And if even one eye is significantly improved, we've done a tremendous amount of good for the patient. And the flip side of that, and let's just have our cake and eat it too, is that if you hurt one eye, as tragic as we feel, if the patient has one eye still good, they are going to do all right. So we treat only one eye in this paradigm, and that's what the 3 clinical trials I'm going to tell you about involve. All of them are the same in that regard. We have 2 gene therapy trials going on, and 1 using this agent Bendavia, and in all cases, double-blind, placebo-controlled within the patient. If the patient has lost vision for less than 6 months, they fall into this trial. If they've lost vision from 6 to 12 months, they fall into that trial. And more than 12 and less than 10 years, they fall into this 3rd trial. We still have a few patients that don't qualify for any of the trials because in all cases, there has to be more than 50 microns of thickness of nerve fiber layer on OCT, which means there's at least some fibers left with which to work. The 2 genetic trials come out of the work from Genzyme in Paris. Their phase 1, phase 2 safety trials showed that it was pretty safe, although they do get 2 problems I want to warn you about. Most of our patients get uveitis, or iritis. Most of our patients have a spike in pressure. The spike in pressure is almost always less than 24 hours, and the iritis resolves within a week as well. But we do caution our patients that we're expecting those issues. And that is, if it's that much of a problem because of the injection of the virus the first time around, I would hate to think what would happen if we ever wanted to treat again, so we're not even contemplating that. This protocol clearly is 1 injection only, but once we have exposed a person to that antigen, I think it would be extremely difficult to do it a second time. But in their particular phase 1 trial, they did see that there were 9 patients, 5 of which showed some benefit, and it just happened that those 5 patients were the ones that would have qualified to our phase 3 trial, which is what we're doing. So that's sort of a positive. This is the phase 3 trial. It's being done in 3 centers. We are, in fact, far ahead of the others in terms of recruitment and injection, but there's a group at Emory and at Wills that are doing it as well. And actually, it's 2 trials because we're doing the acutes, so-called, if it's less than 6 months, and the subacutes, so-called, if it's 6 to 12 months. And ideally, there'll be 36 patients in each of those. We will use visual acuity as a primary endpoint. That's the FDA speaking, of course. But we are looking at a number of other very interesting endpoints. And if it doesn't work out that they qualify for that, they will qualify for Bendavia, which acts very much to support oxidative phosphorylation by holding the complexes in fixed position to each other, which normally cardiolipin does. But cardiolipin itself will react with reactive oxygen species to get distorted, which leads to a vicious cycle as these complexes are moved away from each other. Interestingly, the pioneer work on this agent was done by Bob Kloner right here at Huntington Hospital. He used a rat to do a model of myocardial infarction. And just a few days ago came the results of the first use of this as an IV therapy for very serious mitochondrial myopathies and encephalopathies. And in a double-blind study of these 36 patients, it really does seem to work. So with that, I thank all the people with Lebers, both in Brazil. This is the Brazilian group. We have over 300 of those. And those I've seen in the US, my lab, and my very wonderful collaborators, and look forward to seeing patients referred by you for these trials. This happens to be the Brazilian group, the Brazilian investigators. Thank you very much.